Okay, I'm going to start the webinar now.
Hi, good morning, everyone. My name is Nate Sand, and I am a nurse practitioner in Richmond, Virginia, and have the current honor is serving as the ASMBS Integrative Health President. And I'm going to turn this over to my colleague and friend, Mary O'Kane, to introduce herself.
Hello, everybody. I'm Mary O'Kane. I'm a dietitian in Leeds in the UK, and I'm the current president of IFSO Integrated Health. And just really looking forward to this webinar, which is the first time that ASMBS and IFSO have had a joint integrated health webinar, and we hope it's the first of many. So to you, Nate.
Thank you. We are very excited about this webinar, but more excited about the introduction of our 2022 ASMBS and IFSO indications for metabolic bariatric surgery. It's been well overdue, over 30 years since the NIH had met and developed these guidelines. And we have found that insurances and providers and other industries have used these guidelines, and we really needed to get back into looking at all of the robust literature that is out there, and we're going to cover all of that and specifically talk about how integrative health plays a role in the care both preoperatively and postoperatively for our patients. So very excited to introduce all of our panelists and have them present today. Some housekeeping issues. If you would please put all of your questions in the Q&A section and not the chat. Things can get buried in the chat section, so use the Q&A if you have a question, and we will address all the questions at the end for this webinar. So for each presenter, we will move through each slides and then present everyone at the end with the panelists. If you need any logistic help, you can put that in the chat box. All right, so we will move into our first presenter, and that is Dr. Kathari. He will be presenting an overview of the history and impact on today's global healthcare. And Dr. Kathari is currently the Jean and H. Harlan Stone Chair of the Department of Surgery at Prisma Health in Greenville, South Carolina. He's a professor of surgery at the University of South Carolina, Greenville. Dr. Kathari has authored over 130 publications in peer-reviewed journals, 18 book chapters, and has served as senior editor of the 2011 and the 2021 Surgical Clinics of North America issues dedicated to metabolic bariatric surgery. He's currently the vice president of the Fellowship Council, the immediate past president of the Southwestern Surgical Congress, and the immediate past president of the ASMBS. Dr. Kathari.
Nate, thank you so much for that kind introduction. It's truly a privilege to be with you here this morning, this afternoon, or this evening, depending on where you are joining us from around the world. And it has been my distinct pleasure to serve as the ASMBS president this past year. And one of our crowning achievements was this guideline that we're about to discuss and unpack again, working in collaboration with IFSO. These are my disclosures. They should really have nothing to do with this particular talk. Now, this group knows how complex obesity is as a disease. There's a lot of different components to it, and that's why it's important to actually unpack this and have a separate webinar dedicated to our integrated health colleagues to help us with this. So I'm very excited for this opportunity and for this webinar today. We also know the global impact that obesity has as a disease, coming only behind smoking and, believe it or not, war as an area where we can make an impact in terms of the global social burden on humans. This slide shows patients with a BMI greater than 25, so overweight in terms of the prevalence of this. And then in this slide, you can see patients the prevalence of those with the respective countries with the BMI greater than 30 or the class 1 traditional obesity classification. Here we can actually see the total deaths where any cause, where obesity was a contributing factor. You can see the penetrance of this in the respective countries as well. And then in this slide, tragically, you can see per capita, where obesity deaths were directly related per 100,000 people. Obviously, not only is the disease of obesity have a tremendous impact on the comorbid conditions, but it has a significant economic impact as well. Here we can see in US dollars per capita in billions of dollars from a representative of these different countries, the impact that the total cost of obesity had in these respective countries in US dollars. Another way to look at it is what percentage of the GDP or gross domestic product of any one country is the cost of obesity. And you can see again here of the entire GDP, what percentage of these different countries are impacted by the disease of obesity. And centuries ago, obesity used to be a sign of wealth. And we seem in some ways to be returning to that, where we can see with only a few exceptions, there seems to be a linear correlation with as economic income of these respective countries goes up, so does the prevalence of obesity. So when we continue to look at it, the trends in the future predictions do not look good for us here in the United States or for any of our colleagues, really, respective of your country of origin. And there does seem to be an incremental rise in medical costs associated with rise in BMI. And we all know that along with the obesity is tied to the diabetes. And here we can also see as the obesity epidemic continues to grow, there will be a proportionate amount of diabetes, type 2 diabetes associated with that, and another associated economic burden attached with the treatment of that. So here is per 100,000, a variety of countries, the impact that bariatric surgery has. And so clearly we have opportunities to continue to spread our message, expand our, with our expanded knowledge of this, it's time for an update. And as Nate said, it's been a long time since the 1991 NIH Consensus Conference was convened. And as you can imagine, this was mostly expert opinion, consensus panels, and this would have been data from the 80s that was culminated. So minimally invasive surgery had not really even been, broke out yet. So we've been trapped in the past for quite some time. It's hard to believe that that's the year that actually the internet became widely available, was in 1991. And as an example, here is the American College of Cardiology guidelines for ambulatory cardiac catheterization from 1991. And if we look at this, archaic document, it's hard to believe that, when you look at the age of 75, patients with obesity, patients with peripheral vascular disease, patients with diabetes, these are, no patient would get an ambulatory cardiac catheterization in 2023 because they have updated their guidelines based on a wealth of information. Their interventions have gotten a better safety profile, as have ours. And so, no question, there are benefits to guidelines. Ultimately, they do improve health outcomes. We want them to improve the consistency of care, but again, and around the purpose of these types of worldwide webinars is that ultimately we can influence public policy within your respective countries and models of healthcare. So it's really time to get away from these NIH antiquated guidelines from 1991. It's interesting that even the NIH themselves 5 years later said, don't use these guidelines, but they clearly have been translated verbatim into health plans, insurance policies. And we can't get an update one from the NIH because they've gotten out of the business of creating consensus conference statements. So we are, in essence, trapped in the past. So it is time to abandon this and move forward. And that's what we've done, obviously, between ASMBS and IFSO to create the 2022 updated indications. Now, in the time we have remaining, we're going to go through the major updates and hit the highlights. I'll briefly review those with us again in a visual format as well. So the essence of these guidelines say that MBS is available for patients greater than or equal to 35, regardless of any presence, absence, or severity of the comorbid conditions. Patients should also be indicated if they have a BMI between 30 and 35, as well as we know that the Asian population, that the diabetes and high blood pressure hits those patients of ethnic origin at a lower BMI threshold. So in essence, they've been discriminated against with these traditional guidelines. So we've lowered that BMI threshold to 27.5 for individuals of Asian population. We actually have long-term data now. We have multiple prospective randomized trials that did not exist back in the early 90s. And we have more information around our pediatric and adolescent population. And so we have indications for those as well. There is no magic age cutoff. We know now that we don't practice ages, and we have a frailty index. We look at the patient's physiology, if you will, and say, what is their ability to tolerate this procedure? And so we have other indices that we can use other than arbitrary chronological ages as discriminatory cutoffs for patients that would otherwise qualify. And then the bridge to these other procedures, these are other emerging areas where we've had some literature, but definitely still need more on these cutting edge areas where the surgery, the metabolic bariatric surgery can be a bridge to these other things to actually improve their outcomes, whether that be hip or knee replacement, a complex abdominal hernia repair, or a variety of transplants as well. All right, so let's see if we can. So again, this is just a review. The guidelines were put together with a comprehensive group of both ASMBS and IFSO team members to review the literature. And then, as we know, currently we have this gastric bypass and the sleeve are the predominant operations that are currently being done, but around the world, but there are others as well. And sorry about that. So no, that's going to come back. Unfortunately, that's jumping along, so I'm going to have to maybe just skip that. But just again, to talk about the indications which we had on bridges to surgery, which include BMIs greater than 60 are no longer a cutoff. Patients with cirrhosis, patients in need for LVAD or other expanded indications. For the pediatric population, if they're greater than 120th percentile of the 95th percentile with a comorbid condition, they qualify. Or if they're 140th percent of the 95th percentile without any comorbid conditions, they would qualify as well. And so we look forward to these expanded indications helping us to get our message out to payers and patients alike. Another important achievement of this is that this was done with open access. So you do not have to have a subscription to our journals. These are both available in obesity surgery, as well as surgery for obesity and related diseases. And so we have specifically made this open access so anyone can have access to this. These articles have gotten tremendous uptick in our lay press, which is great, and we need to continue to capitalize on this. So if any of you, even after this webinar, are approached by media, it's important to be able to share this message with the lay press as well. We've also, in the short amount of time that these have already been out, co-published in our two respective journals, we can already see in the short amount of time, in less than 4 months, all of the citations now. And this is really encouraging, because this is the direction we want to go with Doctors Scott Shakora overseeing obesity surgery and Raul Rosenthal overseeing surgery for obesity and related diseases. Is don't reference the 1991 guidelines. We're not, your papers won't even be accepted. You need to be referencing in the method section the new guidelines for what patients qualify moving forward. It's gotten tremendous amount of views and discussion again in our various social media platforms. And so we're very excited for this. We just got to keep this energy and momentum going so that, again, one by one, we can get various payers to fall. And we are slowly seeing these wins. Again, here's somebody in a social media platform sharing how they used the guidelines in a peer-to-peer and got a patient's denial overturned with some of the newer guidelines or newer indications, which was very exciting. We continue to see some of these wins. And certainly in the United States, we've seen certain health plans already choosing to adopt the new guidelines. But we have much work to be done. Here was a recent article in India where some of the doctors in India on the medical side were disagreeing with these guidelines. And so we have these battles to face, not only with the payers, but even some providers. And so how do we overcome that? We overcome that with data and education, and so and forums such as this. And so I really look forward to our integrated health colleagues sharing their insight through their respective specialties for this webinar. Thank you so much.
Thank you, Dr. Kathari, and thank you for your leadership when we met of August of 2021, discussing those, this project. And for everyone, not just the authors on the paper, but all the behind the scenes work from contributors to reviewers, both with ASMBS and IFSO. So I want to give a shout out to everyone there. Next, I'd like to introduce our next panelist speaker, and Dr. Sakalingam, who is a professor of psychiatry at the University of Toronto and the director of bariatric surgery psychosocial program at the Toronto Western Hospital Bariatric Surgery Center of Excellence at the University Health Network in Toronto, Canada. He is a clinician scientist, a physician-in-chief, vice president of education at the Center for Addiction and Mental Health in Toronto. His research focuses on examining predictors of psychosocial outcomes related to obesity care and evaluating psychological treatments for obesity, including virtual treatment modalities in bariatric surgery care. Dr. Sakalingam is also the co-author of the 2020 Canadian Obesity Guidelines with specific focus on mental health. Thank you, and he is going to present today on the new guidelines from a behavioral health perspective.
Thank you for the kind introduction and for the invitation to join today's panel. It's my pleasure to be joining you from Toronto, Ontario, Canada, as a psychosocial director in a bariatric surgery program at the University Health Network and a professor at the University of Toronto, as well as a clinician scientist at the Center for Addiction and Mental Health. And I'm delighted to be representing the behavioral health component of today's panel as we talk about the 2022 guidelines that discuss the indications for metabolic and bariatric surgery. Before I begin, I just wanted to state I have no disclosures related to this presentation. I do hold several research grants from the Canadian Institute of Health Research related to bariatric surgery and obesity care and psychosocial interventions. And what I'm hoping to cover in my short presentation is really the perspectives of a behavioral health provider. I'm a psychiatrist. In the context of bariatric surgery care, as we discuss these 2022 guidelines and some of the expanded indications, I also wanted to underscore, and this is perhaps my conclusion for this presentation, is the continued importance of integrated behavioral health providers as part of that bariatric surgery team, and especially as we're thinking about new indications and new populations where we may be offering bariatric surgery. So before we talk about the new guidelines, I think it's important to just reflect on how behavioral health has evolved in terms of its approach to bariatric surgery over the last 10 plus years. Really, we've been historically been gatekeepers about indicating whether patients should go ahead with surgery or not. But really, it's flipped to a more of a readiness approach and how we might support patient readiness for bariatric surgery. I think this is well aligned with the intent of these 2022 guidelines as we think about new indications and new populations. And really, the behavioral health provider is one member of the team who can help support patients through identification of needs before bariatric surgery and anticipating needs afterwards, including some of those interventions, monitoring supports, which I'll come back to later in this presentation. And I think it speaks to the fact that although we've continued to develop and evolve our recommendations for evaluation, we continue to also underscore how integrated behavioral health services are a core component to bariatric surgery teams, and even more so as we think about extending and reaching to some of these more complex patient populations who could benefit from bariatric surgery. And you can see that in the guidelines, the pre-surgical evaluation process is stated to optimize surgical outcomes. That includes health overall and resolution of comorbidity, but also quality of life, in addition to weight loss, and to implement interventions that can address a number of mental health areas, but particularly disordered eating, which can be problematic for maintaining weight loss, but also kind of engaging in bariatric surgery care, severe uncontrolled mental illness, which is a concern and might be a reason to pause our assessments for more intervention, or active substance use, which can be problematic. And we know alcohol in itself has issues in the post-surgery phase as well. And so the severity of this is important to think about how ready one might be and what interventions we need to provide for bariatric surgery patients. And again, this would apply to the indications in the 2022 guidelines. And I just want to underscore that, despite as we expand patient populations, we still are going to be faced with many patients who have a lifetime history of psychiatric illness. About 2/3 of patients, give or take, kind of 5 to 10%. Depending on the context, and about 1/3 of patients with an active psychiatric illness. And again, these are mood disorders, anxiety disorders, binge eating disorders before surgery, but also substance use disorders for patient populations as well. And so our assessment approach is not going to change with these guidelines. However, I'm going to highlight there are certain things that we may want to focus on as examples in some of these indications. We're still going to think about our weight history to understand some of those challenges and supports and individuals' response and resiliency in those contexts. Eating disorder symptoms, and I'll come back to that given the importance and influence on weight loss outcomes and the long-term weight loss and health benefits. Psychosocial history, again, as we think about some of the indications that are looking at recommending bariatric surgery in our new guidelines for children and adolescents who are really at the higher end of their weight in the context of their developmental history. And I think with that, we need to think about their developmental psychosocial history as well, including supports, housing, finances, food insecurity, and then the health-related behaviors in there, which includes substance use disorders, but also things like adherence, motivation, and expectations with weight loss. So all of these things remain core to our assessment and things we need to apply as we think about expansion and indications for specific populations in the new guidelines. I mentioned that with the new indications for children and adolescents, so those that are 120% of the 95th percentile with major comorbidity related to obesity, or 140% of the 95th percentile, these children and adolescents will still need a comprehensive psychosocial assessment and behavioral health assessment, and really focusing on developmental factors, especially in this patient population. And likewise, we see some of the expansion for older adults in these new indications. And with that, I would say it's important for us to also think about cognitive disorders and how that might impact. Again, patients may have, with age, more cognitive deficits, and this could interfere with behavioral changes, organization, and some of the adherence issues that might emerge. And so a good behavioral health assessment may be beneficial, in addition to other mental health comorbidities like depression, for example, in older adults. And then when we think about revisional surgeries or adjunct therapies for long-term management of post-bariatric surgery, we can't forget about behavioral health interventions that are being influenced by our assessment that might also help with some of the difficulties maintaining weight loss or continuing with remission of obesity-related comorbidities. So again, if we think about this as a longitudinal type of approach and engagement, the risk factors for weight regain after bariatric surgery, which might be a reason to think about revisional surgery, we also need to assess if there's disordered eating, binge eating symptoms, or loss of control over eating. Post-surgery depressive symptoms have also been associated. And then also thinking about what tools do we have as behavioral health providers as part of that bariatric surgery team that can also treat some of those symptoms. So again, psychosocial interventions, and I listed cognitive behavioral therapy as one of many that might target eating psychopathology, depression, or anxiety in that postoperative phase. And then as a psychiatrist, for some of the malabsorptive types of procedures, the levels and therapeutic levels of psychiatric medications may be important in maintaining remission of some of those psychiatric conditions that many of our patients may live with and had previous stability that may become unstable post-surgery. And so this needs to be optimized as well. And I think about just taking a step back, the last 3 years, the COVID-19 pandemic has been an ultimate stressor for all of us, but a stressor for our patients after bariatric surgery. So those patients, there are studies talking about kind of weight regain and changes in weight trajectory, and also psychological distress. And it really has elevated the importance of behavioral health throughout that continuum of care, from pre-surgery to post-surgery, in areas such as education, teaching self-management skills and tools, expanding support systems, including virtual support systems, and delivering direct psychosocial care in person or virtually as part of our current care practices. So again, I think as we think about these guidelines and these new indications, it really, I do hope I've illustrated that behavioral health support is integral as part of that integrated interprofessional team to monitor symptoms, including emergence of new onset or relapse of symptoms, thinking about early behavioral intervention to mitigate some of those symptoms interfering with some of the weight loss benefits, as well as health benefits that patients experience after bariatric surgery, and some of the behavior change as well. And then to reassess if mental health may be one of the factors contributing to weight regain, and perhaps behavioral health intervention can be helpful there to modify those factors or risk factors for our patients. So with that, I do hope I've illustrated that behavioral health assessment is important to understanding, treating, and delivering early and continued intervention as these guidelines expand in terms of indications. And again, comprehensive pre-surgery psychosocial assessment can help us plan not only for the readiness now, but also for the needs post-surgery. And again, as we think about continued monitoring, not just of weight, but of overall health, including mental health, it's important for us to continue to reassess psychosocial factors, particularly if patients are struggling or experiencing weight regain or insufficient weight loss after bariatric surgery. So I'd like to thank you again, and I'm happy to take some questions through our question period.
Thank you very much for an excellent presentation, and I can see in the Q&A that it's generating lots of questions, which we'll try and direct to everybody at the end. So our next speaker is Dr. Elijah Faria, who is a dietitian nutritionist specialising in obesity and bariatric surgery, and she's based in Brazil. She's also a researcher, and many of you will know of her already through her many contributions to nutrition and bariatric surgery. Sylvia is also the president-elect of this integrated health section, and she will become the president at IFSO 2023. So thank you, Sylvia, and I look forward to hearing your presentation.
My pleasure. Thank you, Mary. First of all, I would like to thank IFSO and the ASMBS for the invitation. And I'm going to talk about the registered dietitian section overview of the new guidelines. I have no disclosures. Our last guidelines were from 1991. So last year, IFSO and ASMBS published an update and the indications for metabolic and bariatric surgery. And it has an impact on the registered dietitian's perspective. We are more flexible in terms of BMI and indications for bariatric surgery, and we also have different indications when we talk about ethnic populations, such as Asian Pacific population. We also are more inclusive when we talk about extremes of age and access for bariatric surgery. Metabolic and bariatric surgery in high-risk populations are going to increase as metabolic and bariatric surgery is safer. We also should improve our evaluation or follow-up of the patients. And also, I'm going to talk about revisional surgery. As we are more flexible in BMI indications for bariatric surgery, people with lower BMI, people that have different ethnic features, and also people that present more serious BMI will have more access to metabolic and bariatric surgery. Because of that, a greater number of patients seeking bariatric surgery, a higher number of qualified registered dietitians are needed. Because of that, we need more studies on the eating habits and nutritional status and metabolic and bariatric surgery of the Asian and Pacific population. As an example of that, I brought this paper that came up last year, showing that patients that had bariatric surgery in this area, they present more than 60% were vegetarian and less than 40% were adhering to the vitamin supplementation, and it shows that this population presents a high risk of deficiency of iron, zinc, protein, and B12. Children and adolescents will also have more indication for bariatric and metabolic surgery, and we need registered dietitians that have the expertise of following this population. So they need to be specialized in both metabolic and bariatric surgery and pediatrics. The support from family is very important, and also members qualified to work with this population. The literature have been very clear, showing that we need different specialties that will work with this population, and they have different roles, and all of them are very important, and includes nutritionists. The number of adolescents and the number of children that will have access to bariatric surgery will increase over the time. And this population, they present a higher risk of nutritional deficiencies due to the puberty that comes along with this phase, and also with the eating habits. So this is a concern. And also when we are carrying, or if you're specializing in pediatrics and bariatric surgery, to use more empathy and to have good position in terms of accepting patients' difficulties, instead of just or judging or criticizing, using adequate words and try to find a better way for them to change their eating habits, and also adhering to physical activity, to multivitamins in a more positive way will help this population to decrease their anxiety that comes along with this phase. And also bariatric surgery can increase this anxiety with the results after bariatric surgery, and anxiety can also interfere in the weight loss. So being more comprehensive can help patients to adhere. Elderly population is another population that is more, we are more inclusive with this population in this new guideline. And body composition is something that is challenging because it is not, the methodology is not the same over the world. So there is always a different way of measuring body composition. And the diagnosis of sarcopenia, that is a problem among elderly population and can be even more serious after bariatric surgery. The diagnosis is not very easy to do. Sometimes you have to have a body composition evaluation and measurement of ability to do exercises, the strength. So this is not easy to do because the diagnosis needs more the same methodology, but something that I can do or tell to help registered dietitian to work with this population is to include whatever you use you use for body composition, or if it is a bioelectrical impedance, if it is a DXA, to use it regularly, so you can compare with the last result and you can see if your patient is losing more muscle mass that was expected to happen, and you can change the strategy trying to help your patients should not increase the risk of sarcopenia after bariatric surgery because of their decreased intake of protein and the difficulty in adherence of the supplements. High-risk population will also receive more bariatric surgery as it is safer nowadays. So patients with a higher BMI can have advantage in using a very low-calorie diet in a short period of time before bariatric surgery, so they can decrease their risk. This is an opportunity. This is one of the ways of treating the population, helping them to have an access to metabolic and bariatric surgery in a safer way. And also we should adjust weight loss expectations, that we are more flexible in terms of BMI and excess of weight. Sometimes patients are comparing pounds or kilograms that they lost, but the better way to do that is to analyze this as an excess weight loss percentage. So just be aware that you are showing your patients not just the excess of weight, and also comorbidities, and also the improvement in their quality of life. This is not an easy task because the goal for them most of the time is weight, but we should work on all advantages that metabolic and bariatric surgery has. The patient evaluation should be done with empathy, as I told you, and among the adolescents and children, the technology can help, so patients can feel that they are part of the treatment. They can select what most important goals for them, so they can work and participate in a better way. revisional surgery is a reality. We should address expectation of patients, as probably the metabolic effect is not going to be the same as the first procedure, and guidelines for revisional surgery are needed, and IFSO is working on that. To adapt to the new IFSO and ASMBS guidelines for registered dietitians, we need to increase the number of dietitians that have expertise in this area. We also should promote expertise among professionals that are able to work with adolescents, pediatrics, and bariatric surgery. We also should include have more studies on the nutritional management of revisional surgery and also different ethnic groups. Thank you.
So thank you, Sylvia, for an excellent presentation, and it's great to see so many questions coming in. So I'd like to invite our final speaker, to Nasreen Faris, to present. Nasreen is a doctor specializing in endocrinology and obesity medicine. She's the founder and program director of Obesity Medicine Fellowship in Saudi Arabia, and she chairs the integrated health section of IFSO Munich. She practices endocrinology, diabetes, and obesity medicine at the Obesity, Endocrine, and Metabolism Center at King Fahd Medical City in Riyadh. So it's great to have you here, Nasreen. I know you're a great contributor to integrated health, and obviously we're looking forward to seeing you in Naples as well.
I will be giving today the obesity medicine physician perspective. I do not have any disclosures for this talk. And I think the most pressing question is why the 30-year gap? And I think the importance of having a 30-year gap between the first NIH guidelines published in 1991 and the 2022 ASMBS IFSO guidelines is that this has given us a lot of time to do a lot of good quality studies to evaluate metabolic surgery. And now we have really good data on its long-term efficacy, its long-term safety, the sustainability of the procedures, and benefits beyond weight loss, or what we like to name in obesity medicine as weight loss independent benefits of metabolic surgery, like we see clearly in things like type 2 diabetes. The previous NIH guidelines stated that only individuals with a class 3 obesity could go to have a metabolic surgery, or individuals with class 2 obesity with life-threatening comorbidities. The data on children and adolescents at the time was not very well established, so there were no clear recommendations on surgery for that age group. What we can see here in the 2022 guidelines is that there was a paradigm shift where we saw that there was recommendations for metabolic surgery for class 2 and obesity and above, regardless of the presence of complications, because of the benefits of metabolic surgery, which I'll be discussing a little bit later in the talk, and recommendations for those individuals with class 1 obesity with complications of obesity, especially metabolic complications such as type 2 diabetes. There's also an emphasis on ethnic diversity, where Asian individuals were considered at a lower BMI threshold of BMI of 27.5. And when it comes to children and adolescents, there are clear recommendations in these 2022 guidelines regarding sending them for surgery. Why has it changed? Specifically because of the data showing the safety of laparoscopic metabolic surgery. This is data shown by Ali Aminian and his group, showing the safety of metabolic surgery between the years 2008 and 2012. And I'm just going to focus a little bit on some of the things in the guidelines. Children and adolescents, of course, all of the data that we have from the longitudinal assessments of the bariatric surgery for The teens lab study showed that having metabolic surgery in that age group revealed not only greater weight losses as compared to intensive medical therapy, but greater metabolic benefits. And since that publication in 2014, we've had many more publications from the teens lab study showing cardiovascular benefits, benefits on kidney function, benefits, mortality benefits in that age group. There's also studies that have even demonstrated that metabolic surgery is safe in age groups as young as 5 years of age. And we have data that shows that metabolic surgery really does not negatively impact pubertal development or linear growth in children. So that is not considered really a contraindications to have surgery in those younger age groups. And in the recent published guidelines in January of 23, the American Academy of Pediatrics have adopted those guidelines in their clinical practice guidelines for evaluation in children, for evaluation treatment for children and adolescents with obesity, where they have moved from their usual stance of watchful waiting and to a more intervention-based stance, where earlier intervention in these children was more beneficial, either by pharmacotherapy or with metabolic surgery, where metabolic surgery was recommended for children with class 3 obesity and above, with or without comorbidities, and with class 2 and above with comorbidities, which is a very big change than previous recommendations. When you look at the 22 guidelines, you will see that there is a paradigm shift as well from emphasis on BMI to emphasis on health. So, and we can see that clearly in type 2 diabetes, where it was recommended in those individuals with even class 1 obesity. That's based on a number of studies done by Gertrude Menengroni, for instance, and Philip Schauer and his group in the Stampede trials, revealing that compared to intensive medical therapy, those individuals with obesity and type 2 diabetes fared better when they had metabolic surgery as a treatment as opposed to intensive medical therapy. They had reductions in microvascular complications, and specifically those individuals with type 2 diabetes and ischemic heart disease had a mortality benefit. And here you can see this is the paper in JAMA by Aliminian and his group showing that the Kaplan-Meier curves of individuals who have type 2 diabetes and obesity and underwent metabolic surgery had a greater reduction in incidence and mortality benefit than those non-surgical controls. Just shifting gears here and looking at age as a age for metabolic surgery. The 2022 guidelines were not ageist in their recommendations. They actually had a focus on frailty, really not the number or the age. They took into account complications of obesity, such as type 2 diabetes and hypertension and other complications. This creates more access to our patients with these conditions who actually require metabolic surgery. And our focus with these individuals really is better quality of life, more remission of their complications, better movement for those patients with osteoarthritis, etc. So that's considering age. Metabolic surgery in these guidelines was also looked upon as a bridge to other treatments such as joint arthroplasty, abdominal wall hernia repair, and even as a bridge to solid organ transplants such as kidney transplant, liver transplants, and even heart transplants. We can have these individuals with obesity undergo surgery to get them on the table for the transplant surgery. How about high-risk patients? In 1991 guidelines, we'll see an emphasis on surgery as being risky. and on surgery being as a last result when all else fails. In the 2022 guidelines, we see the highlight of metabolic surgery as a benefit to those patients actually who are high risk, such as those patients with a super obesity BMI of more than 60, patients with liver cirrhosis, patients with heart failure, and so on. There's a special focus on cancer in these guidelines, showing a reduction in cancer risk in individuals with class 2 and 3 obesity up to 50%, and a reduction in cancer mortality when compared to non-surgical controls. And these are just Kaplan-Meier curves showing that not only obesity-associated cancers, but all cancers, really, we see a reduction in mortality in those individuals who have undergone bariatric surgery as compared to the non-surgical controls. Metabolic surgery has a mortality benefit. Swedish obesity subject study published a few years ago shows almost a 30% reduction in mortality over 10 years compared to the non-surgical controls. And meta-analysis of more than 170,000 patients shows that there is a life expectancy increase of about 6.1 years in those individuals who have undergone metabolic surgery. But with all these benefits, patient selection is key. Preoperative evaluation to optimize results of the metabolic surgery is very important. A multidisciplinary approach is important. Emphasis on nutritional status of the patient, mental health, and identification of behaviors. And please, no delay of surgery for weight loss, something that used to be hyped in the past. Now it really shows that there is no scientific foundation for that thought process, and that delaying treatment really does not help, but actually delays life-saving treatment and causes progression of the disease. What are the challenges with having such great guidelines? Really, in 2017, an eye-opener paper showed that only 1% of the population in the US who were eligible for surgery ended up having the surgery. Will the new guidelines allow greater access to care? I think with the insurers, policymakers, healthcare providers, and patients' voice, we can remove these barriers and get greater access to care. Things that I think are future directions is really using first-person language in guidelines. There's a mention of the word obese in the guidelines. Really, it's individuals with obesity that I would like to be used more than the ASMBS and IFSO guidelines. Use of staging systems such as the Edmonton staging system to help other healthcare providers to understand obesity beyond a BMI and start prioritizing and stratifying their patients, addressing the stigma of obesity and the stigma of seeking treatment of obesity is really very important to be mentioned in the guidelines. And emphasis really on long-term monitoring and follow-up of these patients for suboptimal weight loss, micronutrient deficiency, late complications, weight regain, and all of that. Another thing that we should look at is the metabolic surgery, an era of more effective pharmacotherapy. And you can see here data from the STEP trials from semaglutide 2.4 that was approved almost a year before these guidelines were published, about 18% of total body weight loss, the tirzepatide as well, which we are expecting to be approved for obesity in the summer, about 20% of weight loss. We have all these medications. We have others coming along the way. Combination therapy is another thing that needed to be addressed. We do have combination therapy now for weight regain, suboptimal weight loss. We have a lot of prospective trials showing the benefit and retrospective trials showing those benefits. Obesity algorithms, treatment in a way where we have everything in a Venn diagram: microenvironmental targeted therapy, pharmacotherapy, endoscopic intervention, metabolic surgery, and post-surgical combination with our patients in the middle to benefit the most. And I'll end with that, and thank you so much.
All right, as our panelists come back on, I want to, on behalf of Mary and myself, thank our excellent group of professional colleagues here for the great presentations. We're going to start with some questions in the chat, and we've had a lot of interest in behavioral health. So I'm going to bring up the first question as probably a two-part question. One was about information on finding resources for behavioral health, and also a question about post-procedural programs for behavior change at year 1 and year 2 post-op. So I will pose that question for Dr. Suckalingam.
Thanks so much. I'm happy to talk about this. I think this is the ongoing struggle with behavioral health in our current context, bariatric surgery care being no exception. And I think for resources within programs, I think it's first important that people try to realize the importance of behavioral health as part of their team. Think about which team members are available and what can be offered within programs, and then partnerships outside of those with key providers. I will say, again, it's important that we develop those expertise in a range of behavioral health providers. There's no quick fix in terms of where to find one of those. It's kind of building that capacity, and I would recommend that people consider courses. ASMBS has a Fundamentals in Behavioral Health course at the annual conference now, and that might be a great way to kind of build capacity within your team as part of that. In terms of post-op care, I'll just say briefly, probably the biggest interventions and changes we've seen are more virtual interventions that use a bit of step care, from kind of self-directed resources, e-resources, to direct in that area emerging about how to engage people in an effective way. And I would say the last point, culturally adapted services in behavioral health is another area that is emerging, but more to be kind of continued and discussed.
Thank you. There's great compliments coming up in the chat box as well, so I'm distracted by those. Next question, directing to both Nazreen and Sylvia. And obviously we talk about surgery in the older person, and I probably fit that age group now myself, and obviously the risk of sarcopenia as people get older. So as an obesity physician and also as a dietitian, what would you be looking for when actually assessing a patient for bariatric surgery, especially if they're older, and in terms of frailty and sarcopenia and those risks? Because obviously it's not only just about surviving the operation, it's actually 5-10 years later, they're still benefiting from surgery.
Thank you, Mary, for the question. What my main concern about sarcopenia comes with the same concern I have with the body composition evaluation. We don't have just one way of evaluating body composition. Sometimes DXA is not available. So as I told, DXA or bioelectrical impedance is important. But another point that I think is very important is to evaluate protein ingestion in their diet. So I used to do a lot of questionnaires asking and helping patients to know what is a good source of animal protein, how much they are eating per day, if they need to have a protein supplement, how can they take it? Maybe they don't like it because it's very sweet, so I try to give another option. So giving more options of protein supplement and teaching them how to eat more protein, I guess, is very important, together with doing some strength exercises. So this is something that's, since the beginning, I try to tell them. I know that is not something just focused on the elderly or older population, but it is something that we should concern about all of them. But the elderly population are in higher risk, as you told. So I'm always focused on these 2 points.
Thank you for that. As a surgeon, I would say, obviously, working in a multidisciplinary team is obviously critical, taking in the input from all of our integrated health colleagues to make a final decision, yes or no, for surgery. In the context of frailty, for me personally, when I assess a patient, it takes in several components of this. One is what we call the eyeball test. I mean, we know when we see patients who are 50 years old, but they are going on 75. And we've seen 70-year-olds that look like they're going on 50. And so we look at, ambulatory status. We look at physiologic reserve, obviously review of their labs, and then a cardiac and pulmonary evaluation. And I don't like the term, which has gone by the wayside over 10 years ago. I don't like it. And we still see it in the literature, which is cardiac clearance or pulmonary clearance. I mean, the patients aren't cleared. That makes sense. Like there's never a chance anything bad could happen. It's cardiac optimization. It's pulmonary optimization, meaning this patient is in the best shape possible. I've done everything I possibly can to get this patient tuned up and make it as safe as possible for surgery. Doesn't mean there isn't risks involved. And it's important, again, to think that, I think of complications with surgery into major and minor. Major complications, regardless of the procedure: leakage, bleeding, blood clots, potentially life-threatening. And then there's the minor complications, surgical site infection, urinary tract infection, things like that. Patients don't die from the complications. They die from the lack of the physiologic reserve to overcome the complication. And so that's how I have to assess the patient. And I look at him, and nobody wants a major complication, but I look at that patient and go, after this kind of assessment, say, does this patient have the physiologic reserve to combat a complication and bounce back from it, whether it's treated surgically or non-surgically? Can their body tolerate that? And again, that's where surgical judgment, years of experience, and then these handful of frailty calculators that are available on the internet come into play.
Is there anything you'd like to add to that? And also, just tying in with that, there's also that balance now with the newer medications as well. So how do we actually help direct the patient to the right area?
So I think that's a very important question, especially in an era where we have very good pharmacotherapy now. In the next 5 to 10 years, we're probably going to have even better pharmacotherapy. There's a lot of things in the pipelines. I think it's really important for me with the population who are above 65. I tend to think honestly first thing about functionality, activities of daily living, and how exactly are you going to benefit from surgery. And when we talk about medications, I do tell my patients that we still don't have long-term data on the benefits of weight loss through medications, because we know that the benefits of metabolic surgery, there's a number of them are really beyond weight loss. They're weight loss independent benefits, they're metabolic benefits that we still don't know. That, when we have these better medications, maybe the medications have that as well, but we still don't have that data. I agree with both Sylvie and Shanu on the idea of really a lot of protein, a lot of exercise, really looking at patients as individuals, not at the number of or age, and looking at the quality of life. If an older patient is coming in with a box of medication and all they say is, I'm really sick and tired of taking all of these. Can metabolic surgery get me to a point where I can take less, where my quality of life is going to be better? Then I think they deserve to have that conversation, understand the risks that are coming with it, and understand what's going to happen later on. I think this is my 2 cents, and just every patient is very different than the other.
I'd like to follow. I'd like your expertise because obviously, whether it's with pharma or with surgery or conventional means, we want healthy weight loss, and we emphasize protein in the rapid weight loss phase afterwards. But I've seen two, and I'm not an expert in anti-obesity medication, so I defer to you in this group. But I've seen 2 recent publications that talked about some of the weight loss in 2 recent trials for the anti-obesity medications. It was like 38%. Muscle mass was some of the weight loss. And so, is that healthy weight loss? Is that not healthy weight loss? Are there ways to combat that?
So that's another very good question. So the idea is when we lose, and that's probably why we didn't see this data in the earlier trials of previous weight loss medications, because we didn't have medications that gave us this great amount of weight losses, 18%, 20%, and probably with the newer medications, we're even going to see more. When we lose a lot of weight, whatever intervention it is, we lose some muscle mass. There is some data with semaglutide 2.4 showing that really there's a lot of preserved muscle mass with it. There's only data on bimagrumab, which is not FDA approved as of yet, where there's gain of muscle mass, but there's less weight loss. And there's a lot of talk in the obesity medicine community about using that medication specifically post-bariatric surgery to try to maintain muscle mass, because it's the only the only medication that shows muscle mass gain rather than loss. So so when you lose a lot of weight, you will lose muscle mass. It is just a risk of losing a lot of weight, and we just have to talk to our patients about it. We're not used to having that conversation with pharmacotherapy as we are used to having it with bariatric surgery, but I think we should start having those conversations.
I think it's, I shared in my presidential address last year, I think, and it's going to take a while for the nomenclature to catch on, but I think we have to adopt similar to the cancer model where we have neoadjuvant treatments, then we often do surgery, and then we often do adjuvant chemotherapy after surgery to keep the cancer at bay. It's a chronic disease. It can always come back. Patients are in remission. And this is the way we have to go now with our adjuvant treatments, including pharma. It could be neoadjuvant, pharma, then surgery, and then a maintenance phase with adjuvant pharma after plateau. I think it's a really exciting frontier to see where all of these levels of research is. When do you start the pharma in addition to the surgery? Is it during the rapid weight loss? Is it wait till you plateau? Can we ever get to the point where we use these as predictors of responders and non-responders pre-op? Because if you don't lose weight with a GLP-1 analog or whatever, would you really lose weight with a gastric bypass? I think it's a fascinating area for future research for those engaged within our respective societies.
So that's why I alluded to that at the end of my talk, that I would have wished that the new guidelines actually did talk about this combination therapy. And I think with the newer or the updated versions, we're going to see more talk about that, and we're going to have even more data about that. The data is scarce there. There are some prospective trials, there are some retrospective trials, but as of yet, we don't have randomized controlled trials looking at that specifically.
Yes, the multimodal therapy is something that is here and is evolving. So it's a very exciting time to have all of these different treatment modalities. Dr. Sakalingam had alluded to the new development of our ASMBS fundamentals course for behavioral health, and we have our pre-existing Masters of Behavioral Health. We also, in the United States, if you go on ASMBS, we have a list of where you can search by provider, so you can find a behavioral health provider and search out the different radiuses. But yes, trying to find the right clinician for our patients is hard to come by. So things that we're always striving to do and we're working towards. When we talk about access to care, I know that's different throughout the world, but in the United States, we've had a lot of questions here about, have we seen an impact on driving insurance? One of the things that I felt was really amazing was if you do a Google search, the NIH guidelines don't show up on that first page anymore when you start to look at those things. And Dr. Kathari talked about both SORD and obesity surgery, looking at not using NIH referring or citing NIH guidelines, but the new indications, IFSO, ASMBS. And that's the way we're going to turn these things one case at a time. Dr. Kathari, you had mentioned that we have some insurances already changing. I know HCA, whom I work for, has adopted the new guidelines with our insurance coverage starting in January. But can you give some more updates on that, of how we're tracking that and how we can get access to our members?
Yeah, that's great. Thanks for that, Nate. And yeah, I do think, like you said, I think we need to celebrate these wins. I know we have on the ASMBS, we have the Access to Care Committee. And so whenever we get one of these wins, we email it out to everybody so that we can see what's going on. And, this is how we change policy. I always said is like, how do you get a president of a country? It starts, at least in the United States, it starts with at a cafe in Iowa, very small, grassroots, local problem, shaking hands, and then you build momentum. And next thing you know, somebody is in the United States model is in the White House. And so we got to celebrate these small wins and these victories, and slowly it will build, and and so we have, like you said, that's a big one that went by, that fell into compliance with our new guidelines, which is HCA, which is pretty amazing to see that change. We've seen some anecdotal small wins. We've seen some some appeals overturned. One was Horizon Blue Cross Blue Shield of New Jersey, a patient with a BMI 32 with high blood pressure that was denied. And then they actually had the peer-to-peer and shared the guidelines, and they said, wow, okay. And that one, they said that seems like a pretty good argument for the appeal, and so they won that. We've seen components taken on. I believe the Blue Cross Blue Shield of California again has lowered the threshold for the Asian population, which is good to see. And then we've seen some of the state Medicaid plans now have begun to loosen up their criteria around the BMI and revisional surgery. So they are allowing the class 1 BMI 30 to 35 for revisional surgery at some of the state Medicaid plans. So these are just, again, wins. There's probably more out there. We should probably start putting all of these together in some kind of repository so that we can, codify our efforts and start going after some of these other areas that, when you start meeting with your local plans and showing this, shaming them into coverage, basically, to show the out of peer pressure, basically.
No, we're going to be closing soon. There's lots and lots of questions coming in, and it's hard to actually answer them all in this session. But one of the areas I just wanted to touch on was actually the challenging area of pediatric bariatric surgery and what people, think that we must absolutely do. And I know that it's been covered in presentations, but for anybody, what would you recommend to new centres about the challenging area of setting up services for children and adolescents, and also making sure they've actually got that transition into adult services as well? So any quick hits that we can do before we hand back to Nate?
Well,
I mean, I'm not a pediatrician by all means, but since in Saudi Arabia, we are mandated to see patients starting from 14. So 14 is the adult age, because of, in the old days, there weren't enough physicians, and that's how it happens. And then that hasn't been changed as of yet. But because we do see those patients in the adolescent age group 14 and above, it's really very, very challenging when seeing the patients in the younger age group. First of all, you do see them go through a lot of changes in their lives, especially between the ages of 14, the ages of probably 21, 22, going through school, college, getting jobs, a follow-up. We get a lot of loss of follow-up. It's really very hard to get the parents or the guardians involved as much. They may be involved very, very much in the first couple of years, and then those also tend to trickle down. So there are a lot of challenges. And I think a transdisciplinary care rather, and I like to talk about transdisciplinary rather than multidisciplinary, because when we talk about multidisciplinary, I just feel that the patient is going into each room, but everybody's working in silo. When it's a transdisciplinary, everybody's in one room, all the caretakers are talking to each other, and the caregivers, and with the patient as well. So we get that, Venn-like diagram where everybody is involved. So I think there's a lot of that. One of the things that really helps is having groups. So we have patients sit in groups, because teenagers were not listened to, but they probably will listen to each other, especially with, micronutrient deficiencies, taking their vitamins, doing all that. So it takes a village, to say the least. But I think it is very important to not block life-saving surgery for these patients just because they are in that age group that's really hard to deal with. And that's my 2 cents.
No, it's a great response. Dr. Sakalingam, I'd love you to talk about that, because of the different transitions that happen along adolescence. I'm sure that plays into a role too.
Absolutely. And I think as we think about frontal lobe development and maturity, around age 25 or so, and we see kind of the general age that we quote for formation of this, I think decision making and support, and also respecting autonomy during this critical developmental time of adolescence and youth is important. I would say, Nazreen talked about some great points, and I like transdisciplinary. I'd also say thinking about transitions in care, because in Canada, and I'm sure it's not so different in other parts of the world, we have a dichotomy of adult and pediatric care. And then many of patients are coming for bariatric surgery probably around those critical years, around 15, 16 to 18. And then wherever your state or province cutoff might be, you jump from a wonderfully resourced and oriented a pediatric adolescent environment to one where you're an adult required to do all your own appointments. Parents are less involved. So I do think transitional programs that really bridge that gap. We've started to do some of that work in some of our centers in Canada, where we do handoffs and integration over a period of a year to really orient people to the adult system, and think about how do we continue to foster autonomy in our patients. And peer programs, Nazreen, I couldn't agree more, are so powerful during this age, as well as technology. I think there is a way to reach youth in a way that's different than say other populations, and so using things through technology might be beneficial for youth as compared to some other traditional forms of interventions.
Thank you very much. And it definitely been in the chat as well as the question and answer. So something that we have a great new topic to discuss, and in many different levels to discuss these things. I just want to take the time again to thank everyone of the esteemed panelists here for your time and sharing your expertise. All the resources can be found on the repost for the YouTube video, so you can watch that. The links are here, and we will work at addressing everybody's questions and developing new webinars in the future. We'll leave this for any closing comments by any of the other panelists, and then we will close the webinar.
Just want to thank you for the opportunity, Nate and Mary. I think this has been fantastic. Like you said, there's so much to unpack here. We're going to actually need more specialized webinars around everyone's specialties to really do a deeper dive, to really get to everybody's questions around this. But this was a great initial webinar to just scratch the surface of this, of unpacking the guidelines, the new guidelines in the context of our integrated health colleagues.
I think it'd be great to have joint webinars again, and as Nate said, lots of ideas coming up in the chat for future webinars, and certainly children's area is a webinar of its own. From an IFSO point of view, I'm just really pleased with how everything's gone today. It's been fantastic. And a plug for IFSO 23 in Naples, and also just to say that we have got some great news coming for IFSO Integrated Health, because we will be expanding, and there will be opportunities for more integrated health members to become involved as well. So watch, make sure that there's your email and watch for those, and we welcome people coming more on board.
Yes, and thank Mary and Sylvia for those accomplishments in advancing integrative health within IFSO. And our plug for ASMBS will be our national conference in June in Las Vegas. Thank everyone again for your time, and have a